Hello, my name is John Tsai from the UCI School of Medicine, and in this video we will be discussing some interesting renal case studies that will hopefully solidify and enhance your knowledge that you have gained from the previous physiology videos in this lecture series. We'll be going over salt and water regulation again, except in the context where things can go wrong. We will then delve into an interesting case of potassium dysregulation from licorice, why this happens, and review the effects of aldosterone within the kidney. We hope that these interesting cases will not only help solidify your understanding of renal topics, but also help see how the physiology you have learned actually relates to real medical cases that we have seen in clinical practice. Let's first delve into how our bodies handle salt and water again, especially under extreme circumstances. Let's first start by reviewing antidiuretic hormone or ADH. Recall that ADH is produced in response to either a low effective arterial blood volume or high serum osmolality. Most ADH production is physiological or normal, but when ADH is produced abnormally or pathologically, this can lead to sodium and water dysregulation in the body. One of the more common causes of ADH to be produced abnormally is through side effects of medications or drugs, and through other pathological processes occurring in the brain or the lungs that can trick our osmoreceptors in producing abnormal amounts of ADH. Remember that ADH is a hormone that primarily stimulates reuptake of water in the distal tubule. So you can imagine that if ADH levels are persistently high, and if we're drinking water, then the high ADH state is not going to allow that extra water from being excreted from the body and ultimately results in dilution of the sodium and low serum sodium concentrations, otherwise known as hyponatremia. Now let's take a look at how this works in a couple of clinical scenarios. The first scenario I wanted to go over is endurance athletes and what causes hyponatremia in these settings. Every year, there are various reports of people passing out or dying after completing marathons or some other endurance sports. There are several reasons for people to have adverse events to endurance activities, but hyponatremia is certainly a common one that can happen after endurance races in otherwise healthy people. Let's delve into how this works. First, our body loses up to 3 to 5% of body weight from sweat and other fluid losses during the race. The longer the race, the more body weight we tend to lose through sweat. Hot climates can potentially exacerbate these losses. This fluid loss stimulates ADH production that then results in a high drive to reabsorb water. If runners are only drinking water and not any of the electrolyte-containing solutions, then this may result in hyponatremia due to the high water intake without salt intake, and the body reabsorbing the excess free water. Depending upon how low the serum sodium drops, this can cause individuals to simply not feel well, to outright coma or seizures in the extreme situation, as was seen in this Chevron Houston Marathon back in 1999 when they sent 4 runners to the ED that ended up in a coma for a week due to hyponatremia. Fluids that are given during races tend to be hypotonic in nature, either water or even some electrolyte solutions such as Gatorade or Powerade. These are considered hypotonic since they don't have as much sodium concentration as the normal body at around 140 milliequivalents per liter, or 9 grams of salt per liter of water. Sweat losses are about 0.05 to 0.2% saline, so it is recommended that we rehydrate with similarly equivalent solutions. One should remember that the salt losses will be worse for those that secrete more salt compared to the low salt secretors. Training over time helps to acclimatize your body, and the sweat that is produced tends to actually have more free water compared to the sweat when you're not trained. This helps prevent hyponatremia with hypotonic solutions that are ingested during these long races. During endurance runs, most of the replacement solutions now consist of Gatorade or other electrolyte drinks, but previously free water was used, which may have exacerbated hyponatremia in these endurance athletes. We'll see on the next slide how much salt is in Gatorade compared to normal saline, but remember that Gatorade also has calories in the form of sugar to help with immediate energy needs. Here are the differences in sodium concentrations between the various hydration solutions that Pepsi Company, the manufacturer of Gatorade and Propel, put in their electrolyte solutions. This ranges from 160 milligrams to 873 milligrams per liter, compared to the 250 to 2,000 milligrams per liter that we are losing from sweat. These solutions do help to prevent dehydration and allow replenishment of sodium that is lost through sweat. These solutions will be fine for the majority of athletes, especially those who have trained for the marathon and have acclimatized their body, but for those who are untrained and secrete more sodium per liter in their sweat, especially those at the higher range of the 2 grams salt loss per liter of sweat, even the highest sodium concentration in Gatorade may not be sufficient to replace losses and eventually lead to hyponatremia. Now, how do we treat these endurance athletes when they have hyponatremia? Well, we usually want to quickly increase their serum sodium levels, and this is usually through a high concentration of sodium, such as in 3% or hypertonic saline. The small bolus of hypertonic saline is usually enough to bring patients' serum sodium levels up by about 1 to 2 points, and that may be actually the difference between life and death or coma in these cases. Since these are such acute episodes, it is necessary to treat quickly to prevent symptoms and sequelae of hyponatremia, especially cerebral edema, which is the cause of most comas due to hyponatremia. In a similar vein, people can actually die of drinking too much water, even if they're not participating in endurance sports. There are several incidents of people drinking probably too much water, and while we don't necessarily think of water being a harmful substance, any substance in large enough quantities can be dangerous. Just look at flooding and sea level change. In this particular incident, an individual from Indiana died from drinking too much water. She apparently drank a total of 2 liters of water in the span of 20 minutes. Quite a feat, if I may say. Let's see how this can be dangerous through this calculation here. We can speculate that the patient's weight is about 70 kilos, which means that the total body water of this patient is about 35 liters, which is calculated as the weight multiplied by 0.5 as a female. If we also speculate that our original serum sodium is 140 and we are adding 2 liters of free water to the intravascular component at its most extreme, this would cause a dilution of the serum sodium to 132. This drop of 8 points in under 30 minutes can potentially be fatal. While it seems obvious that one could have prevented this by drinking the water slowly, and possibly adding salt, such as that in Gatorade or other commercial hydration solutions, our thirst mechanism is an incredibly powerful force that stimulates the body to sometimes drink way beyond our own capacity to handle free water. The previous example begs the question, what is the maximum amount of water I can drink at a time or in a day that will prevent me from becoming hyponatremic? While it would seem intuitive that one shouldn't usually drink more than 2 liters in 20 minutes, as in the last case, the answer is not quite as obvious as it seems. One has to return to the dilution and concentration aspects of the kidney. If we're going to drink a lot of water, we are going to have to urinate as much free water as we can, and this relates to the maximal dilution of urine that can be produced. In our kidneys, this will be approximately 50 millimoles per liter, which is determined by the medullary concentration gradient, and it's at its least concentrated area at the top of the distal tubule, since we assume that ADH will not be active and we will not have any reabsorption of water at the remainder of the tubule. If we also remember that our body must be in homeostasis and the amount of sodium intake must equal to the amount of sodium output, mostly through our kidneys. In our normal Western diet, we consume about 4 grams of salt a day, which is equivalent to about 200 millimoles of sodium. So if we divide the maximal urine dilution of 50 millimoles per liter, we can urinate about 4 liters of water that is maximally diluted. This means that if we were to drink more than this amount, say 5 liters of water, then we can urinate 4 liters of water based upon the 4 grams of salt we eat, but our kidney is not able to pee out any more fluid since you're already maximally diluted, and hence you will tend to retain that free water in your body, causing hyponatremia until you drink or eat more salt. So, if we're going to be drinking more water, then we will want to eat more salt with it. And now you can understand why the body naturally gravitates towards salty snacks when ingesting high amounts of fluid like alcohol. This is also the mechanism behind psychogenic polydipsia, where some patients are driven to drinking a large amount of free water due to their underlying psychosis that results in hyponatremia. The treatment for this is usually simple, restricting free water intake. But sometimes telling a psychotic patient to do something they don't want to do is very difficult, as you will see in your psychiatric rotations in the future. Now let's talk about ADH states that are inappropriate. Remember that ADH causes reabsorption of water in the kidneys, so abnormal ADH production will do just that, cause additional reabsorption of water in the kidneys. This ultimately leads to an increase in the amount of water in the body, and hence the sodium concentration will decrease, leading to hyponatremia. The treatment of this hyponatremia is to find out what the underlying cause of inappropriate ADH stimulation is and to reduce the free water intake and increase salt intake. In this way, we can sometimes tip the balance of a higher sodium concentration intake to overcome the high ADH state. Now let's talk about a certain deadly example of the inappropriate ADH states. Ecstasy, or NMDA, stimulates inappropriate ADH production in the brain. Since ADH state is high, the patient's natural compensation is to feel thirsty and drink a lot of water, which is what usually people do in the setting of volume depletion, but exactly the wrong thing that we want in this case, since we know that high free water intake will result in dilution of the body's sodium concentration, leading to hyponatremia. One must be very careful of monitoring these patients very carefully and correcting their sodium levels quickly to prevent cerebral edema. While we don't condone the use of these drugs, education about the dangers of hyponatremia in the setting of ecstasy can help us identify this as a cause of hyponatremia quickly and allow us to institute treatment rapidly to prevent further deterioration to coma or death. Now let's talk about what happens to our body when we don't have any ADH production or our V2 receptors don't respond to ADH appropriately. In this situation, we will not be able to retain water, and we will have water excretion or aquaresis. This results in our sodium concentration rising due to the excretion of free water. Because this usually makes us thirsty and pee a lot, this is termed diabetes insipidus, a name which is derived from both Greek and Latin to mean lots of urine lacking taste. This is primarily from the times that physicians used to taste the urine, and sweetness would be diagnostic of diabetes mellitus, whereas diabetes insipidus usually does not have glucose in the urine and will lack any taste to it. Thankfully, we have urine dipsticks that are much more sensitive to glucose, and we don't need to taste anyone's urine anymore to diagnose diabetes insipidus or diabetes mellitus. Now, there are generally two types of diabetes insipidus, or DI. The first being complete lack of ADH production from the brain, specifically the hypothalamus and the posterior pituitary, which we term central DI. This is usually caused by some sort of brain injury or brain issues such as tumors or inflammation. The second is ADH resistance in the kidney, where you have a lot of ADH in the body, but the kidney is not able to respond to it, and it clinically appears as if there is no ADH in the system at all. This is what we term nephrogenic diabetes insipidus. There are both genetic and medication-induced causes of nephrogenic diabetes insipidus, but they all present with high urine output and usually high serum sodium levels. The one medication to know that causes nephrogenic DI is lithium, since this is a common side effect due to destruction of the principal cells in the collecting duct that contain our V2 receptors and help regulate water excretion. What about treatment of DI? Well, if we aren't producing any ADH, we just give the hormone back. DDAVP, or a modified version of the hormone ADH, that has a much higher affinity to V2 receptors in the kidney instead of V1 receptors on the blood vessels to cause vasoconstriction, is given to patients with central DI. Small doses are needed to bring the patient's serum sodium levels back to normal. If it's in the setting of nephrogenic DI, this is much harder to treat and usually relies on patient drinking sufficient amount of water to quench the thirst, which will usually maintain the serum sodium levels at or near normal levels. Some patients that have partial defect or in the V2 receptor can respond to thiazide diuretics or DDAVP, but unfortunately we don't have any other treatment aside from high free water intake for those with complete nephrogenic DI. The Cleveland Clinic actually produces a very good summary of both central and nephrogenic diabetes insipidus for patients, but it is also a good starting point to understanding nephrogenic diabetes insipidus. I've attached the website here to this slide. While we're on the topic of sodium and water, I also wanted to discuss urea handling. In our body, urea is generated as a byproduct of protein metabolism and is freely filtered in the glomerulus and reabsorbed in the tubules, mostly by the process of solute drag with other water and electrolyte absorption. The distal tubule is largely urea impermeable, though, and urea ends up mostly being excreted, hence the term urine. The Deranged Physiology website with the link posted here is another great resource to learn about how urea is handled in the kidney. Medically speaking, we can also use urea for medicinal purposes. The urea powder shown here can be safely ingested. It is then filtered and excreted in the urine, where high concentrations of urea actually cause an increase in the osmotic gradient to allow more water excretion in the tubules. Hence, it is ultimately a type of diuretic. Similarly to when you eat a large steak and need to go pee several hours later due to the high solute load, urea powder works similarly in a potentially more controlled but for sure a less palatable way. Because it leads to a net water excretion as a diuretic, this helps raise the serum sodium levels and is indeed an effective treatment for certain types of hyponatremia, especially those caused by inappropriate ADH production or SIADH. Since urea powder doesn't taste very good by itself, the manufacturers of this particular urea powder have added a lemon-lime flavor to make it somewhat more palatable. But there are other manufacturers that produce flavorless urea powder that can be added to your beverage of choice. Let's recap on what we've learned so far about sodium and water. Always remember that the electrolytes we are dealing with are a concentration. Hence, the serum sodium levels represent the amount of salt divided by the amount of water in our body. And usually, our total body water is a good estimate for the amount of water. Remember that sodium issues in our body is mostly a water problem more than a salt problem. So many of our treatments for sodium issues involve either giving more water or trying to get rid of water in the body. We also briefly went over the way urea can be used as a diuretic to increase water secretion from the body. Let's now switch gears and delve into the interesting world of potassium and aldosterone dysregulation. We will be reviewing the physiology of potassium and aldosterone, and then talk about interesting ways that this system can go wrong. Let us recall that aldosterone is a hormone that is produced during low volume states or high potassium states. Outside of these normal stimulants that result in higher aldosterone production or abnormal response can occur in a couple of ways. First, a high aldosterone level can be produced by an aldosterone secreting tumor. This is a condition that leads to primary hyperaldosteronism or Conn syndrome. Second, if the receptor for aldosterone is activated in some way abnormally outside of high aldosterone levels, this can also mimic high aldosterone levels. Aldosterone usually attaches to the mineralocorticoid receptor in the kidney, which then results in its effects. However, cortisol, which is also a cholesterol derivative hormone, can also attach to the mineralocorticoid receptor, causing activation. The reason why this usually doesn't happen is due to an enzyme called 11-beta-HSD, which cleaves cortisol to cortisone, rendering it inactive and unable to attach to the mineralocorticoid receptor. Whether it's high aldosterone levels in primary hyperaldosteronism, or a defect in the receptor, or some defect in 11-beta-HSD that results in unwanted cortisol erroneously activating the mineralocorticoid receptor, all of these will have the same physiologic effect, which we will explore in the next slide. Any way you activate the mineralocorticoid receptor, this results in translocation of the epithelial sodium channel, or ENaC, in the principal cell. This first step is a very important concept to remember, since it signifies the beginning of this cascade of events that lead to the primary effects of aldosterone. The increase in ENaC channels results in reuptake of sodium in the kidney, and the increase in sodium reabsorption leads to sodium and water retention, which can lead to hypertension. Because the sodium reabsorption mandates a potassium excretion through the ROMK channel, this precipitates low potassium levels or hypokalemia in the body. Lastly, as we discussed in the acid handling lecture, protons are partially excreted through potassium reabsorption of potassium through the proton-potassium ATPase in the alpha intercalated cell. This secretion of protons can lead to a metabolic alkalosis. So if you remember the pattern of hypertension, hyperkalemia, and metabolic alkalosis, then you can quickly narrow your differential diagnosis to something related to aldosterone or its pathway. How is it that we can distinguish between so many different causes of hyperaldosteronism, or things that look like we have high aldosterone levels in the body? Well, we can actually check both renin and aldosterone levels in our body when the body is under a normal volume status. It is important to ensure that patients are euvolemic, since volume depletion results in renin and aldosterone production. There are 3 different scenarios that we can see in this case. The first is a simple case where we have low renin and high aldosterone levels in normal volume states. Remember that renin is usually the precursor to aldosterone in the setting of volume depletion. But if we have low renin and high aldosterone levels, this usually signals that our body is inappropriately producing aldosterone, leading to the clinical triad of hypertension, hypokalemia, and metabolic alkalosis, usually in the setting of an adenoma or abnormal growth of cells that is producing aldosterone. This is again what we call Conn's syndrome. Now, if we have high renin and high aldosterone levels, this is usually the result of high renin production, either in the setting of renal artery stenosis, where the kidneys are not seeing sufficient blood volume, fooling our kidneys into thinking we are volume depleted, or a renin-producing tumor. Again, both of these outside of normal euvolemic conditions. Both of these situations will eventually lead to high aldosterone levels and our triad of hypertension, hypokalemia, and metabolic alkalosis. And if we have both low renin and low aldosterone levels, then we have the triad of hypertension, hypokalemia, and metabolic alkalosis. We should think that there is another factor or mutation that causes what looks like hyperaldosteronism. And since actual aldosterone levels are low, we term the situation pseudo-hyperaldosteronism. There are many ways that pseudo-hyperaldosteronism can occur. Again, through the pathway anywhere from the mineralocorticoid receptor to a mutation in the epithelial sodium channel. Point 1 labeled here is an activating mutation in the ENaC channel that results in the triad of hypertension, hypokalemia, and metabolic alkalosis. This activating mutation is otherwise known as Little syndrome and is usually seen in infants or early childhood. In point 2, cortisol isn't degraded sufficiently into cortisone, or cortisol is produced in such high quantities that it overwhelms the ability of the 11-beta-HSD enzyme to break it down. The 11-beta-HSD deficiency can occur through mutations or medications or glyceric acid ingestion, the primary ingredient of licorice, which blocks the 11-beta-HSD enzyme from working properly to convert the active cortisol to inactive cortisone. In point 3, the enzyme deficiency results in the inability to convert pregnenolone and progesterone into cortisol, which then overloads the DOC enzyme and results in high amounts of aldosterone being produced. Lastly, in point 4, the mineralocorticoid receptor can have a gain-of-function mutation that results in our triad. This situation is called Geller syndrome. Interestingly, affects pregnant patients more compared to non-pregnant patients. You do not need to know all the details of this at the MS1 level, though knowing that there are several mechanisms that can cause pseudo-hyperaldosteronism will be helpful in your clinical practice in the future. Now that we have gone over the pathophysiology of 11-beta-HSD enzyme and how licorice can block the conversion of cortisol to cortisone, you can now see how licorice can actually kill someone. High amounts of licorice root containing the toxin glycyrrhizin can sufficiently block the 11-beta-HSD enzyme, result in activation of the mineralocorticoid receptor by rogue cortisol. In this particular case that was published in the New England Journal of Medicine, the renin and aldosterone levels were both low, pointing to a pseudo-hyperaldosteronism effect. The patient ultimately died from hypokalemia, but had the classic of hypertension, hypokalemia, and metabolic alkalosis in this interesting case. While normal consumption of licorice will not likely cause this, years-long exposure to high amounts of licorice was inevitably this person's cause of death. Additionally, the licorice that is common in today's candies here in the United States don't usually have glyceric acid anymore. So if you're consuming licorice or like licorice, then please consume in moderation and watch your blood pressure. Let's recap on our case study on potassium and aldosterone. Remember that potassium levels are regulated by aldosterone, but high pathologic levels of aldosterone that are either produced by an aldosterone-producing tumor, a renin-producing tumor, or any of the ways it could cause pseudohyperaldosteronism can cause the clinical triad of hypertension, hypokalemia, and metabolic alkalosis. Always look out for this triad, especially when you see a young patient with high blood pressure or someone with new onset high blood pressure, since this is a very common cause of secondary hypertension. That's all I have for you today, but hopefully these interesting cases will help solidify your renal knowledge that you will take to help better treat your future patients. As usual, please feel free to reach out to me if you have any other questions or comments.